Hello, my name is Zeke Clemmens. I'm a PGY2 PM&R resident at Honor Health, and I'll be narrating a presentation on a case of locked-in syndrome in pregnancy. Our patient is a 29-year-old female who presented to the emergency department with seizures and decorticate posturing. Diagnostic studies revealed bilateral pons and left cerebellar infarcts, as well as occlusion of both the right vertebral and basilar artery. She was found as well to have an intrauterine pregnancy estimated at 6 weeks gestation. Her initial hospital course, as mentioned, the seizures in the ED, there was establishment of a form of communication just by yes and no questioning, with yes being upward eye movements and down being no. She was able to, with the assistance of her mother, after a significant discussion with the healthcare providers taking care of her, elected for a chemical abortion. The patient's course was further complicated by loss of horizontal eye movements, as stroke alert was called, and revealed by MRI that she had a progression of the pontine stroke for respiratory failure and significant dysphagia. Patient was given tracheostomy and a PEG tube placed, and then transferred to a skilled nursing facility. While at the skilled nursing facility, the patient developed significant vaginal bleeding, which required acute care transfer, showing severe anemia as well as leukocytosis. The patient did receive blood transfusions. An infectious workup was negative. The managing providers elected for dilation and curettage, which did reveal retained products of conception. Once the patient was stabilized, she was transferred to an acute rehab facility. For completeness, past medical history, none. Past surgical history, none. Family history, none. No significant family history to speak of. Prior level of function, independent, living alone in an apartment. She does have a drug history of fairly frequent marijuana. There was some mention of questionable methamphetamine use in the past, but could not establish any collateral history on that. Just as a side note, this physical exam was approximately 6 weeks following the initial event, initial stroke, but was just some pertinent positives: tracheostomy, PEG tube in place. The neurologic exam showed globally weak cranial nerves, though, as mentioned before, she did have eye movements in the vertical plane, both up and down, that she was pretty consistent in communicating with. There was weak smile on the right, as well as being able to open her mouth slightly on the right side of her face. She did have very weak activation of shoulder, of trapezius muscles to be able to shrug, as well as turn her head side to side with sternocleidomastoid. Sensation was intact, but she was flaccid in her extremities. So what is locked-in syndrome? So it is a brainstem stroke, which is very devastating, resulting in quadriplegia, bulbar palsy, and often whole body sensory loss. Things as similar with our patient that are intact, maybe eye movements, blinking, hearing, and cognitive function, as this is brainstem and not cortical. The most frequent cause is ischemic, but there are 3 subtypes of locked-in syndrome: classic, incomplete, and total. So here are those subtypes here. Total is the most devastating, obviously, with total immobility, inability to communicate, but fully conscious. Classic is what we more commonly hear of: quadriplegic with preserved vertical eye movements and preserved consciousness. Incomplete is classic with other abilities, so it could be voluntary movement of hand or different parts of the face, that kind of thing. Consciousness is present in all these forms and is seen on EEG. As with other strokes, whether brainstem or higher up in the brain, there are different causes. Ischemic, hemorrhagic are frequently the most common, but there are several other possibilities included in the causes. We briefly discussed these previously. Function loss, as mentioned, voluntary breathing, movements, bulbar palsy, can have dizziness and vertigo, retained functions, cognition, hearing, and then the vertical eye movements. In general, focus of our rehabilitation was prevention. Unfortunately, the patient did have 2 UTIs during her acute rehab stay. Our attempts to get established with urology while she was with us for suprapubic tube placement did not happen. However, she is established with urologists now, so hopefully can move forward with that on the outpatient side. Continued to have dysphagia, no changes there, but was able to progress to bolus feeds. On the pulmonary side, continued trach care with our respiratory therapist and our pulmonologist, but no major complications. Skin, she did eventually have a stage 1, but it did improve with diligent wound care and contracture prevention with the Prafos, wrist splints, and regular range of motion. As far as functional progress or therapy, the patient overall didn't make huge significant gains there, but one aspect that was huge for the patient was an increased ability to control head movements, specifically side to side, and even getting more voluntary motion in her proximal muscles in her shoulders. This allowed us to look at options for modifications to a power wheelchair, such as a head turn assist. So with that, she was able to get to a moderate assist, meaning that our therapist or whoever was with her needed to give about 50% of the time cues or helping drive. But that was a huge thing for the patient to be able to accomplish while she was there. Hot on our mind early in her course was prevention of complications. The mortality has been reported here. It notes 60%. Other mortality shows possibly 80%, especially in the first 4 months after the initial event. So these complications most often are pulmonary in nature, so aspiration pneumonias, things from impaired cough or dysphagia, as well as PEs. On the other side would be the mode recovery. How much could we expect for our patient to improve in the time with us? So we will discuss this a little further. As part of our care plan, certainly would be a discussion on expectations of prognosis and recovery for both the patient and the family. The next few slides will focus on some of the recovery aspect, and then just on this slide, something to highlight would be the longevity, that once patients get past that first year, they often have a fairly good survival rate. Data regarding recovery, because it is a really pretty rare condition, is somewhat sparse, so it's very small case series kind of studies, but one in 2003 did show that there's partial or full independence in activities of daily living within 3 to 6 months of onset by 21%, which is 3 of the patients of 14. Complete swallowing ability in almost half. Verbal communication recovered, but did have dysarthria and dysphonia in just over a quarter. Ability to use a device by hand, finger, head movements was achieved in about half, again, 6 of them, and then tracheostomy removal, again, in about half, 6 of the patients. And here is a similar kind of thing done in 2015, again, 14 patients. Again, this is 3 to 6 months, but also shows very similar percentages as seen by the prior study in 2003. This is a video from the study from 2015 showing a patient that had locked-in syndrome and some of their outcomes. Although it may seem quite surprising, but despite the significant life change and adjustment that patients have to go through to get used to their locked-in syndrome, there is a fairly good quality of life based on scales that have been self-reported by a few different studies. So we expect that our patient, based on her frequent like laughing and just engagement with the rehabilitation process, that she will likely have this kind of similar outcome. This concludes my presentation. Here are my references, and thank you for listening.